At the very end of this discussion, there'll be a very short video for people who are coming to the lab this afternoon. It'll just sort of review some of the things that you'll do.
So we have a short discussion now because we also want to show a little instruction for the hands-on course.
Okay.
I have a quick question for Steve. When you approach a new Barrett's patient in your diagnostic and treatment algorithm, and you do your first endoscopy there, do you tell the patient that at the same time you probably ablate them or do an endoscopic resection when you find a pathology in these patients, or you do two endoscopies and the first one is a diagnostic, pure diagnostic one, and then is a therapeutic one?
Yeah, most of the time it's a pure diagnostic endoscopy first, unless the patient is specifically referred with a known lesion, and then I might arrange with them ahead of time to move forward. But I like to get a feel of what the esophagus is first and sit down and talk to the patient about the options a little bit before we embark on anything.
I'm going to follow up. Once you've cleared their esophagus, how long until you recommend they have their anti-reflux procedure?
Yeah, there's kind of two issues there. My preference is to get rid of all the high-grade dysplasia because I really don't want a situation, and we've had 3 patients where I couldn't clear the high-grade dysplasia, and we both decided that enough was enough, and we moved forward with esophagectomy. And if you do an anti-reflux operation before your esophagectomy, obviously you compromise your ability to do the esophagectomy of the gastric polyp a bit. So I try to clear at least all of the high-grade dysplasia, try to get rid of all of the intestinal metaplasia if possible, and usually a surveillance interval about a year before the Nissen to make sure everything looks good. In some patients, though, with really severe reflux, you just can't seem to get it under control with endoscopic therapy, and then you got to make the decision about an anti-reflux operation to control the reflux disease and potentially allow you better ablation, and sometimes that's been successful too.
Can you continue to ablate after you've done your anti-reflux procedure without too much difficulty?
It's easier, actually. The hardest place to get rid of intestinal metaplasia, the place that always fails in all the studies, is right at the gastroesophageal junction. These patients have hiatal hernias. It flares out. It's a hard area to ablate well. After the fundoplication, that area is held tightly, and you get much better ablation, actually.
Do we have any questions from the audience? All right, so the next hurdle, we've proved to the medical people that we're capable. Are they going to quiz us on whether we have the cognitive skills to do this? Do we know about all the disease?
I'd like to hear Chris's answer, but I think this is the area where we need to show a discipline as a group, as surgeons. There are plenty of surgeons that have done this. You have people on the panel today, like the person to my left, that has come from an institution where surgeons have had an incredible track record of contributing in the area of our understanding of foregut disease at the cognitive level, not just at the technical level. But I think one great way to approach this is to meaningfully partner. Chris is a great example of this at his institution, across disciplines and along lines of expertise, where you show respect for your colleagues' abilities, and if there's someone there that has abilities you don't, instead of viewing it as a turf issue, look to work collaboratively with patient care, and optimal patient care is your goal. And the centers that are teaching us the most on both the cognitive and technical front are doing that across disciplines.
Yeah, I agree with that. I think that, you know, there's not a large number of therapeutic endoscopists doing the more advanced procedures either. In many cases, there's as many surgeons as therapeutic endoscopists with most of the suturing and other things that we show. And I think even, you know, anytime you're getting a gastroenterologist who's not used to those therapeutic procedures, there's certain cognitive elements they have to brush up on. Same with surgeons. And I agree completely with working together. When I started doing more of the bariatric endoscopy, I knew nothing about it when I started. I was like doing a mini fellowship with our surgeons there, and they were great and very helpful. And similarly, you know, they'd like to learn more endoscopy, so they're spending more time in the endo unit. And I think that, you know, everyone's different. Some people, it might be more of a technical hurdle they have to get over. Other people might be slightly cognitive, but working together is definitely the best way to solve it.
I think that it's relatively easy on a local level, right? It's easy if you partner with your gastroenterologists or surgeons in your institution, you work together and you know each other and you know the limitations of your skills and stuff. But if you're asking the question on a more broad level, that's, I think, a much more difficult question to answer.
The question is, are they going to require us to take a test? I mean, is that going to be their next ploy?
I think it's probably a little bit more complex than taking a test, and probably the way in the future to go, as we did with laparoscopic fellowships, is create interventional fellowships where gastroenterologists and surgeons can participate, because those are so complex procedures, and with the rise of nodes, it will be even more complex.
Okay. Any questions? Well, I think we'll finish this up. I want to thank all our participants. And if we could run the video. You guys can. You can go. Is it? Where is it? Oh, okay. In the lab, you'll start with rubber band ligation. It was developed in the lab for polyp creation, but as you saw from many of our speakers, they actually use it for resection, which is exactly what's going to happen after this. The general run of the course goes, you create your polyp with the bander, elevate it by doing injection. This is a little bit different than when you do mucosal resection. I believe there'll be a variety of different snare shapes and configurations for use. When this model was developed, this now became your ulcer, but also a way to practice tattooing for marking a lesion for subsequent surgery if you thought necessarily, or marking it for subsequent endoscopic follow-up. There'll be a faculty member at every table who will, you can pick their brains. You can pick the brain of the faculty member at the next table if you want to a little. I believe in the explants you can use the balloon dilator both at the pylorus and at the GE junction. My favorite when with PEG is to try to make the person helping me get the needle to come right through the snare. This is a pull type PEG. I think there may be pull or push type. In this pull peg, what they're doing is showing how the snare gets put around it to help pull your endoscope back down. And the idea is to watch your peg once you're inside and see that it rotates freely. There will be stents available at every table. in the lab, there will be clips, kits for mucosal resection, foreign body retrieval, if you wish. Radiofrequency ablation of GERD, I'm going to show the video. Everyone will rotate through the stations for the radiofrequency ablation of GERD and Barrett's are separate stations from your primary station, but you all rotate through this and spend time there. This is what the device looks like. The purpose of the endoscopy is not only placement of the wire, but to determine your level of treatment. And you can see the endoscope can be put in to watch. This is the circumferential ablation. Followed by the stripping of the tissue. And then the last segment shows the use of the smaller. Thank you. The lab starts at 1:30 in Exhibit Hall D.
I'd like to thank you very much for this course to attend, and I hope you had a very good morning, and I'll see many of you back for the hands-on course.